reconhecido mundialmente como especialista na área de medicina perioperatória. So it's our pleasure to have you here, Dr. Cohn, and please feel free to start your speech. Thank you.
Okay. Thank you, Lucas, for the introduction and the invitation to this meeting. And thanks to the committee for putting together a perioperative session, which is something that I always like to see people do. What I'll be talking about in the next 40 minutes or so is my update of the perioperative cardiac risk assessment and management. And I'm frozen. The screen is not moving. Okay. Here are my disclosures, nothing relevant other than royalties from things that I've written. And as you've just mentioned, thanks for highlighting my recent book, Decision Making in Perioperative Medicine, Clinical Pearls. The objectives of my talk are basically to review the American College of Cardiology, or ACC Guidelines, and their algorithm for preoperative risk assessment. And what I'm trying to do in this talk is to incorporate what I think I would suggest for updates based on some newer studies. The guidelines are currently being updated, but won't be out until the end of 2023. So when we talk about preoperative assessment, we really want to talk about optimization. Our role as consultants is to optimize the patient's medical condition for surgery and not to clear them for surgery. In the United States, the word clear sort of implies a guarantee that the patient will do okay and not have any complications, and we can't give them that kind of guarantee. So we want to say that they're in their optimal medical condition, not that they're cleared. I'm going to focus on the patient with ischemic heart disease. So someone who has CAD, what's important to ask about in the history? First, do they have ischemic symptoms? Ask about chest pain, dyspnea, or syncope. Then assess their functional class. What can they do? Can they do the equivalent of 4 METs, which is what the ACC guidelines use? And if not, why can't they do it? Then, has the patient had a previous myocardial infarction? And if so, when did they have it? A recent MI is defined by the ACC as within 2 months prior to surgery. Then ask about revascularization. Has the patient ever had bypass surgery or PCI? If so, when did they have it? In what setting was it? Was it an elective procedure, or was it done in the setting of acute coronary syndrome? And if they had stents placed, what type of stents and where were they placed? And finally, ask about other prior cardiac workup. Have they had a stress test or a cardiac cath? Ideally, it's important if you can find one in the last year or 2, which is still considered to be current. The ACC defines the urgency of surgery as follows. An emergency operation means the patient has to go to the OR within 6 hours. Urgent surgery, they say within 24 hours, but I tend to extend it to 48 and occasionally maybe even to 72 hours. Time sensitive, and that would be somebody like a hip fracture. Ideally, they should go within 24. Time sensitive surgery, for example, cancer surgery, can be delayed, and they say up to 6 weeks. And purely elective surgery can be delayed indefinitely. They say up to a year, but it doesn't even have to be done if it's purely elective surgery. As far as risk goes, they say combine surgical and patient characteristics and calculate whether the patient is at low risk, which they say is less than 1% chance of major adverse cardiac events, or elevated risk, which is 1% or more. I personally like the old classification where they had low risk less than 1%, intermediate risk between 1 and 5, and high risk over 5%, but they changed it in the last set of guidelines. And they recommend one of 3 calculators to decide on whether the patient is low or elevated risk, and we'll talk about them. So this is what the ACC algorithm looks like. I'm sure you're familiar with it, and I'm not going into all the details, but I want to highlight 3 sets of guidelines and what they use in order to come to their decision-making. The first is preoperative risk estimation, as I mentioned, using clinical and surgical risk. Then they ask about functional capacity. Can you do the equivalent of 4 METs? If you can't do 4 METs and you have an elevated risk, then it brings you to the point where you have to decide whether pharmacologic stress testing is necessary. And then if it's significantly abnormal, you might go on to coronary angiography and revascularization. So those are the 3 basic decision-making points in the ACC guidelines. The recently published 2022 European Society of Cardiology Guidelines, they came out at the end of August, I believe, is a lot different. Here they define 3 groups of surgical risk, low, intermediate, and high, just on the surgical procedure by itself. They don't recommend the use of any specific clinical calculators, but they do mention the RCRI and a new calculator from the American University of Beirut that I'll show you in a minute. Then they say do a clinical exam and electrocardiogram, and they recommend doing biomarkers in everybody who's at intermediate or high risk. As far as functional capacity, they touch on the use of the DASI score, and they also mention stair climbing. And they're very liberal in their recommendations for transthoracic echocardiogram and stress imaging, more so than any of the other guidelines. And then if it's significantly abnormal, potential for coronary angiography. The third major society for guidelines is the Canadian Cardiovascular Society. Their guidelines are from 2017, and we'll look on the right side for elective surgery, and they say that you should do a risk assessment, but they only want to recommend using the Revised Cardiac Risk Index, or RCRI. They say it's the only one that's been externally validated. Then they go on to say, if you're at elevated risk based on your age, an RCRI score of 1 or more, or significant cardiovascular disease, they recommend getting an N-terminal or a pro-BNP or N-terminal pro-BNP. Nothing in their guidelines or their algorithm says anything about assessing functional capacity or doing any cardiac testing or imaging. And then they say if you're at high risk and didn't do a biomarker, or your biomarker is elevated, then they recommend post-op troponins, electrocardiography, and in-hospital shared care management, which is co-management with hospital medicine. So the 3 sets of guidelines are a little bit different, and sometimes dramatically different. For example, here, no recommendation for functional capacity or cardiac testing. So let's look at the risk indices or risk calculators. The 3 that are recommended by the American College of Cardiology are the RCRI, the Gupta or MI cardiac arrest or MICA calculator, and the American College of Surgeons NSQIP calculator. You can see the risk factors that they have. There's some overlap. They all have something about the type of surgery. They all have something about renal disease. And there's something about some cardiovascular disease. The RCRI is the only one that actually has coronary disease as a specific risk factor. And then they have something about diabetes in 2 of them and stroke in 2 of them. What's different, you need to know, is in the outcomes. The RCRI only looked at in-hospital outcomes, and not only MI and cardiac arrest, which is what the other 2 included, but also pulmonary edema, heart block, and VFib. The outcomes for the MICA and the ACS NSQIP calculator are 30-day outcomes and only looked at MI and cardiac arrest. So let's look at these in a little more detail. Here's the RCRI. Tom Lee and colleagues over 20 years ago studied 4,300 patients over the age of 50. And the important thing to remember here is that they had an expected length of stay at least 2 days. This means they did not include same-day surgery, ambulatory procedures, and very low-risk surgery. So you shouldn't use the RCRI for those patients, because if you do, you will overestimate risk. For example, cataract surgery. Patient will have a lot of these risk factors, and you'll think they have a very high risk, when in fact the risk is well under 0.5%. So don't use it for low-risk, same-day ambulatory procedures. They found 6 independent predictors of their outcomes. And as I mentioned on the previous slide, high-risk surgery, history of ischemic heart disease, heart failure, stroke or TIA, diabetes, and in this particular risk calculator, you needed to be treated with insulin, and renal insufficiency, here they defined as a pre-op creatinine greater than 2. Their complications, again, in-hospital complications, not 30-day. And besides MI and cardiac arrest, they also had VFib, complete heart block, and pulmonary edema. It's important to remember what these risk calculators included and excluded. Now, here is a table just showing, based on a number of risk factors, the more risk factors you have, the higher your risk of complications. I personally have always drawn the line between 1 and 2, where I said 0 and 1 were low risk and 2 or more was elevated risk. A lot of my colleagues like to use 1 as being elevated risk, and that's for personal decision making. You can decide what you like. But I will caution you, if you use one of the apps called MD Calc, Do not use it if you want to do the RCRI, because they've incorporated some other studies that were not done the same way or the same patients that were in the RCRI. And in doing so, everybody, even with a score of 0, is at elevated risk with a minimum risk of at least 3%. So don't use the MD calc for RCRI calculations. Now, this is a good calculator in general for separating low versus high risk patients, but it tends to underestimate risk in major vascular surgery, in particular abdominal aortic aneurysm. So I don't use it for major vascular surgery either. The next one is the Gupta MI cardiac arrest calculator. This is from the National Surgery Quality Improvement Program database, several 100,000 patients to develop it, another several hundred to validate it. There are 5 predictors of their outcome, which was 30-day MI or cardiac arrest, or a type of surgery, dependent functional status. Here, you only needed a creatinine greater than 1.5, the ASA, or American Society of Anesthesiology classification, and increasing age. And when they compared themselves to the RCRI, even though it wasn't a true apples-to-apples comparison, they felt that they had better discriminative or predictive ability. And the third calculator is American College of Surgeons NSQIP calculator. You can see here it's much more comprehensive than the other ones. You need to know the procedure CPT code, and they have over 1,500 procedures listed. And then there's 20 other variables that they ask you to fill in. It looks imposing, but it only takes about 2 minutes to do. It then gives you a nice visual display that's color-coded, giving the patient's risk and comparing it to the average risk for other patients undergoing the same procedure. And you can see if it's green, it's below average. If it's red, it's above average. If it's yellow, then you're average. And this is nice to use for a discussion with joint decision-making or shared decision-making with the patient or their family. They can see where they fit on the screen. And in addition to cardiac complications, it predicts a lot of other things. Serious or any complication, pneumonia, VTE, renal failure, etc. There's also a component if you have patients over the age of 65, the geriatric outcomes are predicted for post-op delirium, functional decline, and a few others. So this is the most comprehensive calculator of the bunch and includes things other than cardiac as well. I'd just like to point out a number of other calculators that are not really in widespread use, but they're out there. The first is the Geriatric Sensitive Cardiac Risk Index for patients over 65. The second is the VQI, Vascular Quality Initiative, which has a calculator for patients undergoing vascular surgery as a general calculator, and then a number of specific vascular procedure calculators. For example, carotid endarterectomy, suprainguinal bypass, etc. The one that I think has the most promise is the AUB HAS2 calculator from the American University of Beirut. And this was mentioned, as I said before, in the 2022 ESC guidelines. It's a large prospective study. It's been validated retrospectively a number of times, but not externally yet. And the risk factors here, it has 2 factors for H, 2 for A, and 2 for S. So for H, it's heart disease or a history of heart symptoms, angina and shortness of breath. The 2 for A are age greater than 75 and anemia with a hemoglobin less than 12. And the S is for type of surgery. You get a point for vascular surgery or for emergency surgery. So keep your eye out for this one in the future. I think it may come into play, and it looks like it's better than the RCRI. Now, several new risk factors have emerged from these calculators that are being emphasized: age and anemia. And they've also looked at several different outcomes. Stroke, which I don't personally consider as a real cardiac outcome. It's cardiovascular, but not true cardiac. And MINS, myocardial injury after non-cardiac surgery. And if we start to use MINS as a complication or as an outcome, none of the calculators are really good. They all will grossly underestimate it because MINS occurs in 15 to 20% of surgical patients. Whoops, I just lost it. Next, the calculators the algorithms we're talking about assessing exercise capacity. And the way we do that is by clinician assessment, and that can be very variable depending on who's doing the evaluation and what questions they ask. You can use a more structured questionnaire like the Duke Activity Specific Index or DASI score, or you can maybe ask just a single question, and the one that's being looked at is stair climbing. Other things that can be done that are more cumbersome, take a longer period of time to do, the 6-minute walk test, time up and go, or the gold standard of cardiopulmonary exercise testing. This is what the DASI index looks like. It's a number of questions with point totals if you answer yes. The example I gave you here is the person has about 25 points, which corresponded in the original DASI score index to 5.8 METs. This was not based on surgical patients. This was based on medical patients. And when it turns out, we look at surgical patients, it turns out that the number of METs is much lower than it was in this group. So 25 would probably be approximately 4 METs rather than 5.8 METs. Now, why are we talking about this? There was a study called the METS study, published in The Lancet in 2018 by Daminda Vijay Sundra and colleagues. And what this did was they compared clinician assessment of functional capacity, biomarkers, cardiopulmonary exercise testing, et cetera. And what they found was that clinician assessment of functional capacity did not predict complications. On the other hand, use of the DASI score was associated with predicting post-op complications, and they found a cutoff greater than 34 to predict low risk. When I looked at the numbers, and I showed you the DASI score before and the questions that are there, it's unlikely that the majority of patients that I would see would get 34 points or more, which really wouldn't help me then to say that they're at adequate exercise capacity. And looking at the outcomes and the percentages of complications in the METS trial, I thought that 25 was a better cutoff than 34 if you're willing to accept a slightly higher risk of complications of about 0.5% more. So I think 25 is okay, and that was echoed by Lee Fleischer in his editorial on the right side here in the article in the British Journal of Anesthesia. So 34 is what they found in the study. I think 25 is reasonable. And the other question is, can we use a single question rather than having to go through the entire DASI questionnaire? This was addressed in part by the Basel PMI study by Giovanna Larradi-Busa and colleagues. And what they found was that the inability to climb 2 flights of stairs was independently associated with major adverse cardiac events and mortality. And adding this functional capacity to surgical and clinical risk, you were able to improve risk classification. They have a larger study that's being evaluated for publication right now called the MET Repair Trial, which had over 15,000 patients looking at a single question: can you climb 2 flights of stairs or not, to assess whether the patient will be at increased risk or not. Now, this study had a larger number of patients than the METS trial, and the patients were older and sicker. So it's a little bit more towards the patients that I would see. So I tend to go with maybe the stair climbing might be better than the use of the full DASI score. Now, what about biomarkers? This is something also mentioned in the algorithms. And on the left, from the Annals of Internal Medicine, you have Manuel Giuseppe's paper on pre-op N-terminal proBNP and cardiovascular events after non-cardiac surgery. On the right is a systematic review from the Cochrane group, and they both found the same thing. What did they look at? They noted that an elevated N-terminal proBNP was correlated with increased risk and predicted postoperative complications. The difference here in the paper in the Annals, they used a cutoff of 200 as opposed to what was in the Canadian guidelines that I showed you earlier, where they used a cutoff of 300 for the N-terminal proBNP. They both agreed that the use of biomarkers added prognostic value to the RCRI. So the question is, should we use 200 or 300 as a cutoff? Dr. Giuseppe was actually the lead author of the Canadian guidelines. I think when they revise their guidelines, we'll probably see it drop to 200. Now, here's some of the biomarker data, so you get an idea where they got their information from. On the left side, they looked at N-terminal proBNP less than 300 or BNP less than 92. And you can see the comparison. The risk of having a myocardial infarction or death at 30 days is less than 5% if you were below 300 and above 21% if you were above 300. That's why they use that cutoff. On the right side, this is the Annals paper The baseline here is patients who had N-terminal proBNP less than 100, very low risk, then between 100 and 200, and then you see it dramatically increases compared to baseline once you get to 200 and above. That's where she drew her cutoff of 200. And on the bottom here, you see the adjusted odds ratio for having complications based on the use of natriuretic peptides is approximately 2. And the area under the curve for predicting things was about 0.7. So it's okay, but not great, but not bad. Now, the recent ESC guidelines recommended preoperative troponin. You can also get your BNP, but they preferred troponin. And they were looking at high sensitivity troponin. And here in this table, you see troponin T levels. And they compared patients who had perioperative myocardial injury, which is an elevated troponin for any cause, as opposed to MINS, where you had to have an ischemic etiology, or no perioperative myocardial injury. And those who had myocardial injury or elevated troponins postoperatively were likely to have a higher mean preoperative troponin that you can see here, 28 versus 12, a higher maximum postoperative troponin, 64 versus 15, and a larger change in the maximum. Here it is 25, an increase of 25 as opposed to an increase of 2. So they felt that this is more useful to have. It also serves two other purposes. One, if it's normal to start with, it means that you probably did not have myocardial infarction in the last couple of days just before surgery, although most patients have never had that. But it also gives you a baseline. So if you're planning to do postoperative troponins, as soon as you get that first postoperative troponin, you now have a baseline for comparison. So if somebody had an elevated troponin preoperatively and you get one postoperatively, you know that this is not necessarily anything different so far. Whereas if you didn't have it, you might think that they were having perioperative myocardial injury or MINS. And this side, this graph is showing you that the absolute increase in troponin as well as the maximum troponin T both correlate with 30-day mortality. The higher the absolute change and the higher the maximum, the higher the 30-day mortality. Now back to the ACC guidelines. What do they say about stress testing? They say it's reasonable for patients who are at elevated risk and have poor functional capacity, but only if, and this is a big if, it will change management. What does that mean? That means not just that they're going to be considered for cardiac cath and revascularization if it's abnormal. There are other options if it's abnormal. Maybe there's a lesser procedure that can be done, maybe an endovascular as opposed to an open vascular procedure. For cancer patients, maybe chemotherapy and radiation as opposed to a massive surgical resection. And for patients going for purely elective surgery, for example, a joint replacement, maybe no surgery. They don't need to have anything at all, and they'll just have to adjust their pain management. They also say routine angiography is not recommended. So putting these things together, these new studies that have come out since 2014, this is what I put in the chapter I wrote for my book, how I think the ACC algorithm should be changed or what I would like to see. So the first thing is where they used to say, has the patient had acute coronary syndrome? I break it down into 3 groups. I ask about ischemic symptoms or cardiac history. Do they have new or worsening symptoms or never been evaluated? Those patients need a cardiac evaluation. Have they had a recent ACS or PCI or bypass surgery in the past year? If so, here's how we approach them according to the guidelines. And have they had stable coronary disease with some form of coronary evaluation in the past year? If that's been okay, they go to the OR with no further testing. That's the first step that I would like to see changed. The next one, in terms of estimating a risk of major adverse cardiac events, you can use one of the 3 calculators. That's okay. Maybe we'll be using one of the new ones that I mentioned. And then for functional capacity, either use the DASI score, but I like a cutoff of 25, not 34, or use stair climbing, the ability to climb 2 flights. If the decision is still unclear, here's where I put in the N-terminal proBNP, because I don't like to get a lot of stress tests. They rarely change management. So if you're on the fence, you're not sure whether or not to get a stress test, here's where I would do your biomarker. If it's below the cutoff, they go to the OR with no further testing. If it's elevated, then you sit down and have a discussion with the patient, the surgeon, the anesthesiologist. Should we proceed with further testing? And then if testing is very bad, consider angiography. So we'll see what happens next year when the guidelines come out. Now, we've determined that the patient is at elevated risk. What can we do to reduce that risk? First thing is prophylactic coronary intervention or revascularization. And unfortunately, the bottom line, as you see here in yellow, is that we have no evidence of better outcome versus medical therapy alone. And the reason for that is because revascularization carries its own risk. So a patient who undergoes bypass surgery has a 1% chance of mortality, 1 to 2% chance of having a perioperative MI, 1 to 2% chance of having a stroke. So if you don't have at least a 5% chance of complications with your non-cardiac surgery, you're not going to see any benefit by revascularizing the patient, certainly not short term. PCI has a lower risk, but then we have to deal with the problem of dual antiplatelet therapy and the duration that we have to wait before surgery. There are only 2 randomized controlled trials on prophylactic revascularization before non-cardiac surgery. The CARP trial from the VA, 510 patients with stable cardiac disease awaiting elective vascular surgery who were randomized to medical therapy with or without revascularization. They found no difference in 30-day MI or death, and no difference in their primary outcome, which was long-term mortality about 2.5 years later. In the subgroup who had revascularization, they found that patients who had bypass surgery did a little better than those with PCI, probably because it was a more complete revascularization. And in those who were excluded from the study with left main disease, we know that left main disease patients will do better with bypass surgery. The other small study was a pilot study, the Decrease 5, 101 patients with really ugly looking dobutamine stress echoes, randomized to medical therapy with or without revascularization, and again, no difference in short or long-term morbidity and mortality. So we have no evidence that doing this as a prophylactic measure is helpful. On the other hand, the patient who's already been revascularized, they survived it, they're now asymptomatic, compared to a similar patient who was treated medically, there may be some potential benefit. And this is based on the registry from the coronary artery surgery study. But that's not the same as saying we need to do this before surgery. Frozen again. Okay. So the guidelines say about revascularization basically follow existing clinical practice guidelines. That means if you weren't going to do it without surgery, you probably don't need to do it just because the patient's going for surgery. And it's not recommended exclusively to reduce perioperative cardiac events because we haven't been able to show that it does that. Now, what about the patient who's had PCI? We need to balance the risk of stent thrombosis if we discontinue or interrupt dual antiplatelet therapy or do it prematurely. And we also have to balance that against the increased risk of bleeding with antiplatelet agents on board. So we individualize our decisions. We base it on the urgency and type of surgery, patient's clinical risk factors, and then some things that are important for increased risk for stent thrombosis. On the patient side, if the stent was placed in the setting of an acute coronary syndrome, or the patient has a low ejection fraction, or diabetes, or is older, there's a higher risk for stent thrombosis. If the procedure involved stenting the LAD or left main, or they had multiple stents, there's a higher risk for stent thrombosis. And if the lesion was a bifurcation, long lesion, or narrow lesion, there's a higher risk for stent thrombosis. So it's important to get the cath report and find out exactly what was done, where was it placed, and what was the setting. Then we have to figure out how to manage antiplatelet therapy. So this was a small update, not specifically for non-cardiac surgery, but the last 3 pages dealt with non-cardiac surgery in patients who had PCI. It came out by Levine in 2016. And it says that elective non-cardiac surgery should be delayed for 30 days or more after bare metal stenting, and optimally 6 months after drug-eluting stent implantation. It used to be 12 months. They dropped it to 6 months in 2016. However, they give you the option here on the bottom where it says elective non-cardiac surgery after drug-eluting stent in patients who need to stop the P2Y12 inhibitor may be considered after 3 months if the risk of further delay of surgery is greater than the expected risk of stent thrombosis. So what they're saying is that if you have a patient, for example, a cancer patient, who has been on dual antiplatelet therapy for 2 months, but needs to have surgery for a tumor that was just diagnosed, you don't want to wait another 4 months. They'll let you go after 3 months of dual antiplatelet therapy and then continue aspirin. So that was something different in 2016. Now, what's new a couple of months ago from the European guidelines is they break it down in a similar fashion, and they say, was the stent placed in the setting of acute coronary syndrome, or do they have other high-risk ischemic features, some of the things I mentioned about the type of stenting? If so, those patients still go in the same classification. For ACS, you basically are recommended to have 12 months of dual antiplatelet therapy. You can go to surgery basically after 6 months. 3 to 6 months is what they had in the Levine thing. That was okay. So that's your shortest period of dual antiplatelet therapy that they recommend, because class 3 is harmful. So 3 months or more if it's purely elective stent. On the other hand, if it's an acute coronary syndrome setting or other high-risk features, that's where it was for risk features and ACS. Six months, but rather than saying 3 months, which they do for the higher risk patients, they say you may be able to go after 1 month. So that's something that's new. Now, what do we do for patients for antiplatelet therapy? If they had a recent stent, we're going to continue dual antiplatelet therapy as long as we can based on the guidelines. Once that's been done, you typically will drop the P2Y12 inhibitor and continue aspirin indefinitely. For secondary prophylaxis, patients who are on aspirin for that, I like to continue it perioperatively, although the POISE-2 trial suggested that you shouldn't do that. There was no benefit, and they may have higher risk of bleeding. However, the CHEST guidelines that just came out for perioperative anticoagulation, as well as the European Society of Cardiology guidelines, both say continue aspirin perioperatively, and they don't specify whether you were on it for a stent or not. If you do have to stop it, then they recommend stopping aspirin 3 to 7 days before surgery, clopidogrel 5 to 7 days before, and prasugrel 7 days before. These 3 drugs are irreversible platelet inhibitors, which means that all the platelets in your system are currently non-functional, and you need to generate a new pool of platelets, which will take a minimum of 3 or 4 days to get at least 50,000 or more platelets. For ticagrelor, it's reversible, so once the drug is out of the system, your current platelets will resume normal function. That will take about 3 days. The guidelines from the Europeans were 3 days. In the United States, it was 5 days. In some newer studies in non-surgical patients, we're seeing shorter duration of dual antiplatelet therapy, especially in patients who are at high risk for bleeding. And these 1 to 3 month durations may carry over into the surgical patients over the next few years. The other trend that I'm seeing is the use of P2Y12 inhibitor as a sole agent. Instead of continuing aspirin and stopping the P2Y12, they're reversing it because they're using a shorter duration, so they want a more potent platelet inhibitor on board. So we'll have to see how the surgeons respond to having the P2Y12 inhibitor, or do we have to change it back to aspirin before surgery? Now, some other medical things we can do. The beta blockers, still controversial. On the left is Don Polderman's, and there were questions about scientific integrity of his decreased trials. On the right is PJ Devereaux, the principal investigator of the POISE trial, the largest prophylactic beta blocker trial to date. And there were questions about the high dose of extended release metoprolol that he used. Now, this is to summarize what we know so far, is basically a Cochrane systematic review from 2019. Everybody will agree that perioperative beta blockers decrease ischemia and myocardial infarction, non-fatal MI, and they increase the risk of hypotension and bradycardia. The issues are stroke, which the previous Cochrane review said that there was an increased risk in stroke based primarily on the POISE trial. For some reason, they changed their mind in the most recent review and say that the effect is now neutral. And for total mortality, again, because of POISE, it was uncertain, so we're not sure what to do. So although you may decrease non-fatal MIs, it may be offset by increasing mortality and possibly increasing stroke. This is the current state of the art in terms of recommendations or outcomes with perioperative beta blockers. The ACC guidelines say that if you're on a beta blocker, you should continue it perioperatively because we know that stopping it will cause rebound ischemia and hypertension in these patients who are not in any of the trials. They say if you have ischemia on a stress test, it may be reasonable to start a perioperative beta blocker, and I agree with that. But the other thing that they have in here is if you had 3 or more RCRI factors, it may be reasonable to start as well. We used to do that, but I haven't done that probably in 10 years or so. The other thing they say, if you're going to start a beta blocker before surgery, it should be at least more than 1 day before. Don't start it on the day of surgery as they did in POISE, because that was shown to cause harm. They don't tell you that bisoprolol and atenolol, the more cardioselective beta blockers, may be better than metoprolol. This is indirect evidence. I would probably start a beta blocker at least 1 week, maybe 2 weeks before, so you can see what the effect is on heart rate and blood pressure and be able to titrate it. And by the way, the positive trials with beta blockers all use dose titration and the cardioselective drugs. And in observational trials, just being on a beta blocker was shown to be beneficial. Now, what about statins? Again, if you're on the statin, you should continue it perioperatively. If you're going for vascular surgery and you're not on a statin, the guidelines say that it's reasonable to start, and these patients should have been on it anyway. And the third guideline here says that you may consider starting it preoperatively in patients who have other indications if they're going for elevated risk procedures. So example, a diabetic patient or somebody with hyperlipidemia who should be on a statin but is not on a statin, it's very reasonable to start that drug before surgery. They don't tell you which statin. Ideally, it should be a longer acting statin to prevent withdrawal, because there is such a thing as statin withdrawal in patients who are on chronic statin therapy who stop it for at least 4 or 5 days. And a more potent statin, more potent in the pleiotropic effects, meaning more anti-inflammatory or plaque stabilization effect, not necessarily effect on cholesterol. And the 2 drugs that are probably the ones to recommend would be rosuvastatin or atorvastatin. As far as the dose, they say use a moderate to high dose. So if you were going to use atorvastatin where the maximum is 80, I would use 50% of the maximum and start them at 40 milligrams. When to start it is unclear. The earlier, the better. We have some evidence that there may be a benefit very early on in patients who went to the cath lab for PCI, who were started on a statin the day before. Patients who were on a statin had a lower incidence of post-procedure troponin elevations. And as far as harm, the downside, there's really no evidence that I've seen of harmful effects in terms of increased rhabdomyolysis, increased elevated liver function tests. The only thing I did see is one observational study showed that being on the highest dose of a statin had a slight increase in post-op AKI. Now, everything I talked about so far was ischemic heart disease. Just a few comments on other things like heart failure, valvular disease, and arrhythmias. So we know that the risk is higher in patients who have systolic versus diastolic heart failure. So HFrEF is worse than HFpEF. We also know that patients who are symptomatic from their heart failure have a higher risk of complications than those patients who have no symptoms. And if a patient's been recently hospitalized for heart failure, the recommendation is to wait or delay elective surgery for at least 1 month. As far as treatment goes, we give them the usual medications. And as far as indications for echoes, if the diagnosis is unclear, you're not sure if their current symptoms are related to heart failure or not, or if they have new or worsening symptoms, then a transthoracic echo is indicated. For valvular heart disease, we know that the risk is higher with stenotic lesions compared to regurgitant lesions, and aortic stenosis and mitral stenosis are the highest risk valvular lesions we can have. Echo is indicated if you suspect moderate to severe disease and a patient really hasn't been diagnosed, or if they have a change in symptoms. And the other recommendation is that you should delay elective surgery for symptomatic severe aortic stenosis. They should have their valves replaced before elective surgery. And caution with other lesions. You can proceed with appropriate monitoring. They're not clear exactly what that is, but some of the new guidelines, both from the ACC for valvular heart disease and from the European guidelines, are now suggesting that maybe there should be interventions for some of these other lesions as well before you have elective non-cardiac surgery. And as far as arrhythmias, the risk is primarily related to hemodynamic compromise. Is the heart rate too slow, too fast? Is the blood pressure too low because of it? And you need to control the heart rate in patients with atrial fibrillation. It's not clear what the optimum heart rate is. The maximum is no more than 110. I like to have it less than 90. Then if a patient has a device implanted, you need to get the interrogation report. If it's a pacemaker, you need to report within 12 months. For an AICD, within 6 months. And what you're looking for on these reports is battery life, evidence of arrhythmias, is the patient pacemaker dependent, and have they been shocked? You may need to get the people involved to reprogram the pacemaker before, or the ASCD before surgery, in addition to using a magnet maybe. And then finally, if they're on antiarrhythmic meds, they should be continued. So some new studies just to be aware of. The POISE-3 trial, part of it was published in the New England Journal a few months back. It showed there was a benefit of tranexamic acid in patients undergoing non-cardiac surgery, not just orthopedic surgery, in terms of decreased bleeding. The second half is currently being evaluated for publication, and they looked at two different strategies, one for hypotension avoidance, the other for hypertension avoidance, in terms of managing the patient's antihypertensive meds before surgery. The bottom line is it didn't really seem to matter what you did. They both had the same outcome. I mentioned the MET repair trial earlier, and this is going to be looking at the ability to climb 2 flights of stairs, predicting lower risk. And if they publish that and it confirms the Basel PMI, I think that's something to be used for assessing exercise capacity. Just to repeat a few of the things from the recent ACC Guidelines, they do recommend more liberal testing than the ACC Guidelines in terms of more electrocardiograms, other blood tests, echoes, and biomarkers. They did have something new, as I showed you, for time-sensitive surgery after PCI, maybe as early as 1 month if it's done in an elective setting, or 3 months rather than the 3 to 6 month period. They also recommended continuing aspirin and restarting it early postoperatively as opposed to the POISE-2 trial. And they had more liberal recommendations in terms of valve replacement or repair before surgery. The other set of guidelines I mentioned, the ACCP or chest guidelines on perioperative anticoagulation management, is something you should look at. And we're expecting the update from the ACC hopefully by the end of 2023, if not early 2024. I have no idea what they're doing. I'm not on the committee, but will hopefully be a reviewer when they do, before they come out. So to summarize what we talked about today, for risk assessment, use the ACC algorithm with modifications that I suggested. Separate patients into low versus elevated risk using one of the calculators. If they're at elevated risk and can't do 4 METs, then consider pharmacologic stress testing, but only if the results change management. For interventions, prophylactic revascularization is rarely necessary just to get a patient through surgery. So if you weren't going to do it, if they didn't have surgery, you probably don't need to do it. For medical management, non-cardiac surgery may be okay 1 to 3 months after the procedure, not having to wait 6 months anymore, and try to continue either aspirin or dual antiplatelet therapy. We have nothing new in terms of beta blocker, and the data remains controversial, and statins are potentially helpful with little downside. And finally, this whole process of perioperative evaluation and management involves communication and collaboration. This is a team approach with shared decision-making, and we need to get everybody involved, from the patient, patient's family, the surgeon, anesthesiologist, and consultant. The goal is to make the patient, put the patient in their optimal medical condition before surgery, with the outcome being fewer or no postoperative cardiac complications. And with that, I'll stop. Thanks for your invitation again, and I'll take any questions that you may have. My email address is here, scohn@med.miami.edu, if you have any questions you want to send to me. And I frequently tweet things on Twitter @preopconsult. Once or twice a week, I'll put something out on new articles in the literature. So if you want to stay current and know what's going on with my 2 cents in terms of my interpretation of the study, you can follow me on Twitter. Thanks. Any questions?